Good evening, and thank you for joining today's program. My name is Renee Sanchez, and on behalf of the NYU Myers Alumni Association, I want to thank you for joining us today for this special program. We have a panel of experts with us tonight to share their experiences working with victims and survivors of human trafficking and how nurses can join in their fight. Most trafficking victims will have contact with healthcare during their exploitation, including at primary care settings, reproductive health clinics, medical specialties, mental health, substance use disorder treatments, or most often emergency departments. The health consequences of being trafficked can be a wide-ranging and unique to any type of exploitation. Increasingly, healthcare professionals are learning to look for signs of trafficking and to treat victims with the respect that they deserve. I will now introduce our speakers for tonight. Dr. Veronica Ades is a Vice Chair of Obstetrics and Gynecology at Jacobi Medical Center. In addition, Dr. Ades is an Associate Professor of Obstetrics and Gynecology and Director of Global Women's Health at New York University School of Medicine. She is the founder and director of the Empower Center at Governor Health, which provides comprehensive trauma-informed medical and social services to survivors of commercial sexual exploitation and other forms of sexual and gender-based violence. Bernard Freeman is a professor of law at Emirates at Seton Hall Law School and an adjunct professor at the law at New York University School of Law. Mr. Freeman has taught a variety of courses, including slavery, human trafficking, and the law. He founded, organized, and directed a study abroad program focused on slavery and human trafficking based in Zanzibar, Tanzania. He is widely published and continues to be involved in the number of anti-slavery and anti-trafficking initiatives, particularly in the Muslim world. Ingrid Johnson is the manager of patient care access's Overlook Medical Center. She represents Atlantic Health System in New Jersey Coalition Against Human Trafficking, where she's a founding member and serves as a co-chair of the Healthcare Committee. Ms. Johnson serves as a national expert on the American Hospital Association's Human Trafficking Advisory Committee. She is the mother of a survivor. In 2004, her 13-year-old daughter was missing for 11 months, and she worked closely with law enforcement to rescue her. Dorelia Vasquez is a graduate NYU Silver and a holistic psychotherapist. Ms. Vasquez established Rockland County's first human trafficking program in 2015. She is the founder of Planting Seeds Healing, an integrative holistic movement, Center for Healing and Commitment one makes to themselves, where she supports BIPOC women and communities to become their authentic whole selves. Dorelia is currently conducting research exploring the experience of Latinx childhood survivors of sexual abuse and is the adjunct professor at NYU. Dr. Jamesetta Halley-Boyce will be our moderator this evening. She has served in a number of offices in the hospital C-suite, including CEO, COO, and Chief Nurse Executive Officer. Dr. Halley-Boyce maintains her own consultant firm and additionally, and recently retired as an associate professor and director of Health Systems Administration graduate program in the College of Nursing at Seton Hall University. I'm going to turn it over to Jane Zetta, who will be our moderating the questions this evening with our guests. We will have immediately following a Q&A session immediately after. If you want to start adding your questions into the chat, go ahead, but we will be asking those questions after our panel discussion. Thank you.
And thank you, Renee. And welcome to everyone. Welcome to our panelists. What a joy and honor for me to be able to sit here and raise questions with experts. I certainly consider each of you an expert in what you do. I'd like to start with a question that might seem like an easy question, but it really isn't. Human trafficking. Human trafficking has many definitions, certainly possibly even when you consider some myths associated with it. But may I ask from each of your perspectives, a very diverse group, would you please each define for our listeners tonight, what is human trafficking from your perspective? Ingrid, may we start with you, please?
Hi, good evening. And so taking the definition from our state of New Jersey website, some of the training materials, human trafficking is modern day slavery and involves the use of force, fraud, or coercion to exploit a person for labor or commercial sex. Now, you must know that if you're a minor under the age of 18, you do not have to prove force, fraud, or coercion. And you should also know that human trafficking doesn't have to involve smuggling, and it doesn't have to involve being moved across state lines or international lines. And those are some of the myths that we like to dispel tonight. Thank you.
Okay. Bernard, may I ask, from your perspective as an attorney, would you define the same term for us, human trafficking?
I agree with everything that Ingrid said. And for me as a lawyer, the first thing that comes to your mind is that it's a crime, but there's also a history associated with that crime that goes back to the time of slavery. In 1865, the US abolished slavery, but a lot of the practices that are very close to slavery continued and even in some cases, became worse. So there were international efforts to define slavery, but the criminals kept doing things in advance of the law. They stayed one step ahead of the law. And so in 2000, we really came up with this, it's not just a crime, but it's a new crime. So this idea of force, fraud, and coercion, or with children, and sex trafficking, labor trafficking, but there's also such things as organ trafficking, people mostly internationally, trading in organs and other things like that. And so it's very much a not easily prosecuted crime. And then also it's related to prostitution. Sometimes that's a crime. And there are lots of people who think that it shouldn't be a crime. And so trafficking is complicated from a lawyer's perspective. I'd say it's a very complicated topic legally. And then you have the federal law, which Ingrid recited, and also it's very similar to the New Jersey law. But there's also the New York law and other states. In each state, depending on where you are, the law might be a little different in terms of prosecuting trafficking.
That's interesting. Very interesting. Veronica, welcome. May I ask, from your perspective as a physician, how you define human trafficking?
I think Ingrid summarized it perfectly. I don't have anything to add to the definition. I would say just that I'm not a lawyer, so for me, it doesn't really matter, but it is helpful to note that each state has its definition. There's a federal definition, and there's also an international definition. I tend to rely on the Palermo Protocol, which is well known within trafficking circles. Those definitions are pretty similar, but I also like to highlight what Ingrid pointed out, which is that unlike drug trafficking, human trafficking doesn't require the crossing of borders at all. And that's a common misconception.
Okay, all right. All right. I'd like to just raise the issue about myths and types. Can we speak to different types of human trafficking? And may I ask you to do that with your definition, Elia?
Yeah, of course. Good evening, everyone. So when I define human trafficking, I look at it as sex trafficking, labor trafficking, and then the exploitation of children, knowing that children cannot give consent. So we don't need to define human trafficking with force, fraud, and coercion. With sexual exploitation and labor exploitation, there is force, fraud, and coercion involved. One of the biggest myths that I always like to dispute is that I think with the word trafficking, some people think that there needs to be movement. Trafficking can also be domestic. I think that word always like tricks people a little bit, but we can have, and there's many cases, most cases that I have worked with are domestic trafficking that happen in our communities in plain sight.
Okay, thank you. Thank you for that. If we were to ask you to recognize human trafficking in our practices. As nurses, we practice in many, many different areas. Can you help us as nurses to be able to recognize human trafficking? May we continue with you, Dariella?
Yes, of course. So when I think of helping out nurses, I really like to look at their setting and where they're meeting survivors. So I would really give different tips, sort of say, for someone working in ER versus someone working in pediatric setting. However, my biggest, especially, you know, as a holistic psychotherapist, my biggest takeaway and my biggest tip is to meet people where they're at, right? I always say, especially working with survivors, that real recognizes real. So when we open up and provide effective communication, when we provide resources, when we provide a kind and compassionate service, survivors will speak. A lot of time, often, survivors aren't believed or heard. But we as professionals, whether it's healthcare or in this criminal justice system, if we meet them where they're at and provide the information and do that prevention work, there's a beautiful chance that they're going to come back and disclose or trust us in order to get them to the resources that they need.
And trust is a very big issue with that population. Veronica, can you share from your perspective also?
Yeah, I'm happy to. So obviously I'm not a nurse, but I think working in the medical field, I can speak to that, and I work with nurses. I think one of the most important conversations going right now in the medical world among those of us interested in trafficking is how we can best identify trafficking victims and survivors, and whether screening is appropriate. And by screening, I mean applying some kind of screening tool to an asymptomatic population. So not necessarily somebody that you suspect may be trafficked because of things that they say or certain characteristics, but to everybody. There's a lot of discussion about screening. And so I actually run a lab called the Empower Lab, where we research the intersection of sexual and gender-based violence. And we looked into this very question, and we actually have a publication pending, submitted for review at a journal, because a lot of people do advocate for screening. But when we actually look at the screening tools that are out there, very, very few of them have been validated. It's really important to validate a screening tool and not just assume that it's a good. I think a lot of people assume that, hey, if you screen for trafficking, you catch people, no harm done. But there are harms of screening, just like there are harms of doing mammograms for screening, even pap smears, that you can have false positives, you can have a lot of stress and anxiety. Screening for interpersonal issues may have less medical risk. But we also know from the literature on domestic violence that there are risks to screening. And so you do need to know what your harms might be. Specifically, in another study that we did, we asked sex trafficking survivors whether they had contact with the medical system while they were being trafficked and what that experience was like. In our study, about half of them had, with the informal or formal medical system. So some of it was just a guy in a room who may have been unlicensed, but a lot of it was the formal medical system. But in about 90% of those visits, the trafficking victim was accompanied by the trafficker or the trafficker's representative. So it's important to remember that many trafficking survivors may not be fully able to participate in their visit, or even if they're alone with the doctor, that their trafficker is right outside the door. And so disclosure comes with a lot of risks. I think in medicine, we often want to save the person. We want to intervene right away. And so even if we were able to get that person to disclose in the moment, it may not be safe for them. The trafficker may immediately be aware if there's any delay in them coming out. If hospital police shows up, the trafficker may become violent. It could be a risk to that individual or to the staff members and the doctor taking care of them. So it's really important for us to understand this. It's actually a very fraught time, and traffickers are not likely to bring their victims to healthcare unless there's a serious situation. So at that time, they themselves the trafficker is also stressed and concerned. They also know that in medicine, we screen for things like domestic violence, and there's a lot of overlap between domestic violence and trafficking. And so it's not necessarily the case that we know that it's safe. So we are advocating for more validation of screening tools, but also what I would really like to have is identification mechanisms that aren't necessarily applied to everybody, but study who might be a good person to be screened. So for example, should everybody presenting to the emergency room for sexual assault be screened? Should everybody presenting for substance use or abuse be screened? Should everybody reporting domestic violence be screened? I don't think these questions are answered. I'm just asking them that these may be target populations. I had a trauma surgeon come to me who said, I think that a lot of our trauma surgeries are actually trafficked individuals here in the Bronx. And I want a way to figure out how to identify them in a way that's sensitive to the fact that they're undergoing serious surgery right now. And then I think another factor to remember is that a lot of people have a myth, to get back to your question about myths, that trafficking survivors are kidnapped in a room and desperate to be discovered and desperate to get out. That's not the reality of trafficking. And coercion is a really important word there. That many people who are trafficked and exploited because of trauma bonding, or what we used to call Stockholm syndrome, identify with their trafficker, identify with the person who's exploiting them, and sometimes don't realize in the moment how much they're being exploited, and it's only later that they do. So the screening tools are designed to get around that and ask some questions, even if the individual themselves doesn't recognize the exploitation. But again, that gets back to the question of safety. If you're helping them recognize that and encouraging them to do something that they're not ready for, or they themselves don't even recognize it's time for, or that they need, that can be fraught. And then that even if you offered them an escape or an out, they are not wanting it. And I actually do see, I get called from the pediatric service about either adolescents or young adults who are over 18, but on the pediatric service, who are very likely in commercial sex and are being exploited, but don't consider themselves to be exploited and don't want to talk to me. And so it's a very difficult situation. I think the best thing that nurses can do is be sensitive and see if there's a red flag, if there's a sign that something may be wrong, whether it's abuse or trafficking, other forms of violence, to stop and ask, hey, what's going on? This is a little weird. Or I'm noticing that the person that you're with is a little intense. Or, you know, he didn't want you to come into the room alone. Are you okay? What's going on? Now, they may not answer you truthfully, and that's okay. That's their right to lie to you. But sometimes that plants the seed that this person cares, that this nurse or this doctor that I just saw stopped and asked that question, even though I was there for a pap smear or a cough or a COVID vaccine, right? But they cared and they asked, and I didn't realize that somebody would actually ask. And so maybe it's the second or the third or the 78th person who asks them a personal question that gets them to realize that somebody does care. So all of those interactions, even if they don't liberate the person in the moment, can be helpful.
I thank you. I thank you. You said a number of items that I would like to maybe go back and just ask Ms. Ingrid and Bernard, if you want to speak to the idea of practice, identifying it in your practice area for nurses. Anything you wish to add?
Yes, thank you. So I think it's important to continue along with what Dr. Veronica has started, which is trafficking victims can be any age, any race, any gender, any nationality, and surprise, surprise, they could be US citizens. And no one seems to want to believe that. And so when we talk about safety and rescue, I think we also need to clarify that some of the adult survivors do not like the term rescue. They are not seen as rescue. That is a term that is more appropriately applied to minors under the age of 18. Dr. Veronica started talking about that trauma bonding process. So if you research that a little bit more, you may learn why they feel that way and that adults are not typically associated with a rescue. There's a lot involved there. And then we're backing into that trusting relationship again, that's so important. And as a nurse, to me, that's the hallmark of my training, that we are to build trusting relationship with our patients. And I thought about that when it came to my own daughter. And then the last thing, I think I had two other things, that there is no special look. So we can give you and provide you with some basic information. If you check any state website, any evidence-based practice and literature, they're going to share with you what the best that they can on how human trafficking looks. Like someone showing up with no passport or don't know where they are. They can't answer legitimate questions that we may ask our patients. And the whole thing just seems mystifying. You know, if you do a home visit, everybody's sleeping on the floor on mattresses and just a whole lot of other things that go along with that. But the last thing, two things, they're hiding in plain sight. And that's the issue. So when you think that you're just going to go out and receive training and identify these folks, the issue is they are hiding in plain sight. So we need to develop these trusting relationships and utilize our trainings in healthcare and in the community at large so that we can help identify them and not think we're going to rely on them self-identifying. And the last thing is, this means that everyone has a role in the fight against human trafficking. Don't feel like, what's your angle, what's your role? Just keep with us tonight and listen in, and then follow up after this session tonight to understand you can't escape responsibility. We all have a responsibility in the fight against human trafficking.
We all do, we all do. Okay, we've identified some barriers to providing care for this population. And I know we've used the term victim and survivor, but can you identify, and I'll go back to you, Dariella, please, some of the barriers to delivering care for this population?
Yeah, thank you. So I think I'm going to piggyback on Ingrid because you brought up such a good point with trust. A lot of the survivors and victims that I used to work with were women of color. Women, especially Black and brown girls, and looking at trust in systems. I always say when I'm training talking about human trafficking, that human trafficking is a system issue, right? So women of color are not believed, heard, and supported in every single system, whether we're talking about the healthcare system, the criminal justice system, the school system. So going back to also what Dr. Veronica said, those seeds are planted that in these external systems, people don't care about me, and it gets watered and it grows to these beliefs. A big barrier to care and to receiving services, whatever services we're talking about, is that trust component. And if we look at this from a trauma lens, it is so traumatic to feel betrayed by the collective, by the family, by the systems. There's so much levels of trauma there. And as we know, when someone goes through a traumatic experience, it's like walls are being put up and walls and walls and walls. And the most important part of our work, as Ingrid was saying, is that trust and meeting folks where they're at. The biggest barrier is working with survivors and meeting them where they're at, and knowing that although we want to help them and although that we want to be there for them, that they have their own self-determination and that they have agency and choice in their life and how they want to proceed.
Okay.
I wanted to go back to the other topic that what Dr. Addis said was extremely important. And from a lawyer's perspective, it's helps us focus on the fact that nurses oftentimes have relationships with law enforcement people. That law enforcement people are involved in this trafficking business from another perspective. And sometimes that's good, and sometimes that's bad. Sometimes the victim wants to run away, or the survivor wants to run away from law enforcement. So it's important for a nurse, it seems to me, especially the administration, the nursing administration in the hospital, as well as the other forms of administration, to get to know, what is law enforcement doing about this problem? Is it safe? Can they provide a safe place for this victim? Sometimes the victim's acting, or the survivor's acting very rationally. That the one thing about the trafficker is that he does provide safety from the rest of the world. He may be violent himself, it's usually a he, sometimes a she may be violent, but for the rest of the world, that's the survivor who often has not had family, that's really their only family. So if you're going to turn them over to law enforcement or refer them to these social services agencies, you have to, the nurse has, it seems to me, has an obligation to find out where you're sending the person. This is a very good book. I wanted to ask the students to read. It's called Girls Like Us. It's a little dated now, but not too badly, by a woman named Rachel Lloyd. And they have a social service organization in Brooklyn, I think, and New York, and Manhattan, called GEMS, G-E-M-S. And there's quite a bit of literature on what happens to these, especially in sex trafficking on the street in New York, which is a bad problem. The Manhattan DA just announced yesterday that they're not going to prosecute prostitution cases anymore in Manhattan. So, so that is, I think, going to have a significant impact on how people have to deal with trafficking, because a lot of it, sex trafficking, has to do mostly with prostitution.
Okay. Before I go back to the previous question about health disparities and our determinants of care, can we stay with this safe space idea? May I ask, Veronica, would you speak to creating a safe space for survivors and victims?
Sure. And I just want to also, on the theme of terminology, why I'm using both the word victim and survivor. Yes. And it also relates back to barriers to care. I think a lot of times when we have conversations about trafficking, we're often thinking about the people who are still being trafficked and how to get them out. But there are a lot of survivors, people who are already out. Our research showed that the vast majority of trafficking survivors either get out through law enforcement, being arrested or some interaction with law enforcement, or by themselves, they decide to leave. And so there are a lot of people out there in the community who have a history of having been trafficked. And because of the way that trafficking is seen, they're often viewed as prostitutes. And there's a very blurry line between those two things. And so there are efforts being focused on identification now, but unfortunately, not a lot on aftercare. And that's most of what I do in the Empower Center, is I see people who have survived commercial sexual exploitation. And so one of the barriers is the fact that we're not really focusing on the fact that survivors need a lot. I created the Empower Center because I came across a woman who had been trafficked from Mexico. And I realized that she had a lot of trauma and needed specialized services. And so I decided to teach myself. And so I started accepting these patients. At that time, a large part of the volume was coming from Latin America. The pattern there is that people were romantically coerced. They would meet a man, be together for a few months. I love you. Let's move north, make some money, come back, start a family. And then when she gets here, he has her passport. She needs to pay him back for the trip. But the other thing that I found in doing the trafficking work is that another pattern, which both Ingrid and Darielle alluded to, is there's a huge foster care to trafficking pipeline in the United States. A lot of trafficked girls and women are Black and brown. There's a lot of Black girls in New York City who are trafficked. A lot of them have a history in the foster care system. The ones who don't often have a lot of family instability or history of abuse. So there's a lot of vulnerabilities there. And when I meet with them as survivors, often they have not completely figured out their past and the connection to all of the vulnerabilities that they were exposed to. And part of my role in being a trauma-informed doctor is to help them understand that it's not their fault. I think that there's still a narrative. I ruined myself. I chose this. I did this. I'm dirty. I'm bad. I'm garbage. People have used all of those words to me. And what I try to help them understand is, I see this a lot, and I see the same patterns over and over, especially foster care. Foster care, foster care, foster care. There's a direct pipeline. But also childhood sexual abuse. I've had patients say to me, well, I became promiscuous when I was 11 or 14. There's no such thing as a promiscuous 11 or 14-year-old. They're acting out things that they've been taught somehow, and often that has to do with a history of abuse. So, those patterns are really important to recognize and understand, because then they lead to barriers to care, because those former foster girls are angry. They often have misbehavior in their record, or, behavioral disorders. Sometimes they're diagnosed with bipolar disorder, and then they're not trusted by the medical system. And then they have really negative healthcare experiences, and they're seen as just a prostitute or trash or a drug addict. And all of these things that they've suffered and been through, right, are totally ignored. And in fact, the trafficking that happened was often a coping mechanism for them to stay alive. They engaged in survival sex because they had no other alternative or opportunity. They kept themselves alive. Is it a choice? It's hard to call that a choice, because when the other option is death, then it's not really a choice. But that was a coping mechanism to keep them alive, but it led them to other dangers. So I'm sorry if I got a little bit off track, but I wanted to just kind of come back to that. And then to just circle back to the victim versus survivor, people go back and forth. So it's not always the case that once somebody leaves trafficking, that they go on and, go to college and become a lawyer, right? They often have a record. They often have economic difficulties, emotional difficulties that make it really hard to get ahead. And so sometimes they will go back into it, and then that's seen as then now they're choosing it, even if they didn't choose it before, but it's really hard to get out of. And that's why in the Empower Center, what we are doing is providing comprehensive care. So we don't just have medical care. We have a GYN, a primary care provider, and a psychiatrist and a therapist. But we also have, more importantly, in my opinion, a peer care navigator who's a survivor of trafficking herself, an economic empowerment specialist who helps our clients work toward their economic goals, whether it's getting a GED, learning English, creating a resume, going to job fairs, whatever it is that they need to get on track. We have a full-time lawyer to help with legal issues that they might have, anything from criminal to immigration to family law, or they can help refer to the right kind of lawyer. And we have case managers. So it's really that comprehensive support, not just the single opportunity or identification. It's that comprehensive support that really helps, helps give people the opportunities. We also don't force people to stop. If they're, in commercial sex, they're also welcome to stay in it, but we need to make sure that people are protected and safe. So we do have clients who are continuing to engage in commercial sex, and it's completely their, as long as they're an adult, it's completely their right to continue. But often they do have the challenges that I just mentioned.
Right.
And putting those connections together and giving them that support helps them at least live the life that they would like to be living.
I heard you say a lot of things. Do you provide any type of supportive housing? When we think of being a public health issue, homelessness, I would think might be something found in that population.
That's a great point. Our program itself doesn't have funding to actually have housing and implement housing or offer it because it's very expensive and difficult, but there are actually trafficking shelters. So our case managers are able to work with the existing structures within the city to connect people to trafficking shelters and other forms of shelter. There are family shelters, et cetera. And so we consider it kind of an integrated service. If it's something we don't offer, then we help facilitate getting you there, and we work with the organizations that do.
That's excellent. Dariella, I kept seeing your head. Please join in. Feel free to add to what Veronica has said, or to share from your perspective if you feel differently about the two things, the social determinants of healthcare, as well as the idea of creating a safe space.
Yeah, I think I was just nodding in admiration of Dr. Brown.
I do that too, it's normal.
And I also wanted to add, I think another population that so often just is on the side is the LGBTQIA community plus. And just, when Dr. Veronica mentioned survival, my mind went there and into my work working in community centers and in pride centers, and where a lot of youth, unfortunately, were put out of their home, and survival sex was a really big part of how they were surviving and how they were coping, and providing comprehensive services to vulnerable populations, I think, is one of the key ways that we can support survivors and victims in this movement.
Okay, thank you. Ms. Ingrid, anything from your perspective with regard to social determinants, as well as creating a safe space?
I just think that we all have a role to play, that safety is where you are right now. And so if I can meet someone and offer them a smile and offer them acceptance, and you should know that people feel judgment, you don't have to speak judgment. And so if we could practice not judging people, which is very common, it's what we do as a people, I think we can then open that door to build that trusting relationship to help people. I also was thinking, I need to mention that my daughter's case and my family's case is a very unique case. My daughter was 13 in 2005, and she went missing from New Jersey. I recovered her in New York City, and an area in Bed-Stuyvesant I had never been in my entire life, and nor had my daughter. She doesn't know how she got to the New York train station. She was drugged some type of way, and then she was missing for 11 months. She got away and made one phone call hiding in a gas station bathroom in New York City. And then it still took months. She still went missing, still listed with law enforcement. And they had to get a subpoena to trace my phone records to the tower that was used to make the call in New York. Other than that, we were still looking for her in New Jersey. And so because I was a nurse, because of my training, because of the assessment skills, that gut feeling that we get, that we can acknowledge something, that is how I found my daughter. So we are, as healthcare providers, uniquely trained. There is no other person who is trained like we are, so we are uniquely trained. We are trained to hone into critical thinking and our assessment skills, and we are here to save lives. And we need to consider this public health emergency with those affected by human trafficking and jump on board.
Jump on board, I like that. Feet first, jump in. Anyone else wish to speak to that whole idea of social determinants? And I have to say, when we actually looked at the American Hospital Association, their presentation, there was quite a lot of discussion on safe space and the involvement of law enforcement. Would either of you, any of you, certainly Dr. Bernard, would you like to speak to the involvement of police and how we can involve them safely? And then, Ms. Ingrid, I'd like for you to speak to the same thing with respect to the hospital. The hospital has its own security. Right. And how are you able to dialogue and make a safe space for these individuals?
I think what Ingrid just said is very powerful and very important. That and as a nurse, I'm a lawyer. I've never worked as a nurse, but I kind of have an idea what nurses do since I've been taken care of by nurses myself. Mm-hmm. Sometimes you are actually, it's like any other disease or public health problem. Slavery and trafficking are they're almost like evils in society. So you could be the difference as a nurse between somebody who survives and somebody who gets killed, or if they go back to the wrong place at the wrong time. So your relationship with law enforcement is really important. And so I would say that it's law enforcement, as Ingrid points out, that was able to help her find her daughter. And oftentimes it's going to be a nurse in those situations who can either separate the victim / survivor from the criminal, or at least start them in the right direction and not send them in the wrong direction. And so I don't think to be frank, from a civil lawyer's perspective, I don't think law enforcement is doing anywhere near enough what should be done with this problem. You have a special victims unit or some sort of, depends on the police department. Some are better than others. You have a unit that deals with this kind of thing, but in the big city like New York or Newark, New Jersey, or Philadelphia, you have to have a really well-educated and well-oiled machine between the healthcare professionals and law enforcement to stamp this out, because we need to stamp it out, and everybody should be working to do that, just as Ingrid said.
Okay. Ms. Ingrid, from the hospital perspective, the hospital security, is there any particular relationship with them, any particular training and education for those individuals who work in hospital security?
So yes, in New Jersey, now most of you are New Yorkers. I think I'm outnumbered
both
tonight.
places.
Right? In New Jersey, we have a mandate that all within our hospitals be trained in human trafficking, but it is a one-time training. And so upon hire, you are to receive that training. Now, there is no mandate on any specialized training within different divisions, including security. But I will say that within the state of New Jersey, law enforcement has been at the table. And I haven't been back to New York to know any updates about New York, but I think they may be probably pretty similar in that there are divisions who are responsible, but the training is not where it should be. And therefore the follow-up and the response is not where it should be. Regarding EMS as an example, if you call and EMS needs law enforcement is at the scene with EMS. What we're working to do is provide basically sensitivity training so that law enforcement can assist and not thinking you're just there to lock people up. You're there to help us help people. And so, you know, and if all we're going to do is, as law enforcement in this nation is show up to lock people up, then why would anybody come forward? You know, and so, you know, so it's a catch-22 when you say the word law enforcement. Why wait around to see what they're going to do? You know, and so, yes, there's a lot of work. There's enough work for all of us, quite frankly, to do, including law enforcement. But if we form teams, as we've done at our hospital, as an example, Overlook Medical Center, we're a member of Atlantic Health System. We are the pilot for the system. I am a co-chair of our emergency department, human trafficking committee, and law enforcement serves on that committee. And so we're tasked with reviewing evidence-based information and determining the next steps for our organization. So you can go to learn about law enforcement. You can Google about human trafficking law enforcement. You'll find information. You can go to the American Hospital Association and you'll see what we all should be doing. And so, yes, law enforcement's at the table. And if it wasn't for law enforcement, I would not have found my daughter. I will tell you that in 2005, the New York police never left my side. I had my daughter's photo, and they said when I showed up to New York just to post flyers in the vicinity of where the call was made, not even knowing where my daughter was, they said she doesn't look like that anymore. So I was pretty disheartened. So I went around posting flyers. I worked with the law enforcement to, once they got my phone record, I'm the one who made the calls. I said, if no one else is trained to do this, I will do it. So I have a background in behavioral health, et cetera, et cetera. And I made the calls and swore to them that I would not put my own life in jeopardy. I went through housing developments in New York, riding around as I met people through phone calls. And I was the one in my personal vehicle waiting outside in the darkness out of train station in New York with undercover police cars behind me, waiting for hours to see if they would release my daughter to me. And so law enforcement is key. And I don't think it's anyone's fault if we have a lack of training. And that's why we're here tonight. And so better late than never.
Very much so. Very much so. May I go back to Dr. Veronica? Would you like to add any comment about the
thank you.
Security and police?
Yes, I wanted to say something. Although before I say that, I just want to say, Ingrid, your story is terrifying. And thank you for sharing it, because I can't imagine how difficult that was at the time. And it's just so important for people to understand that this happens to everyday people. And the strength that you had to get through that for your daughter, I'm a parent myself, and I would probably tear the person limb from limb myself if that happened to me. So really, I congratulate you for all the effort that you did to bring your daughter back. I'm sure she's very grateful, but I can't imagine how horrible that must have been.
Thank you.
So to speak a little bit more to law enforcement, because I do think it's interesting what law enforcement has been doing, at least I can speak to New York City. I do think that there are police officers that are interested in this issue and understand, but it's not the vast majority. So there are certain ones who are trained, right? The rest of them, as Ingrid said, get maybe like 1 hour or something. But there are people who have units and they understand it better. And when you speak to those officers, there's a shared language there. But also interestingly, New York City developed what's called diversion courts, where they realize that a lot of people who are labeled as prostitutes and maybe labeled as voluntary prostitutes, it's really hard to tell. So they really kind of put all sex work related crimes through these diversion courts in order to just kind of provide opportunities and support. What's really interesting, I visited the diversion courts, and what's interesting about them is how differently they work from every other court in New York, because the judge, the prosecutors, and the district attorney, public defenders all meet together to talk about operations and how to optimize things, which is like never the case in other forms of court. They, you know, it's really adversarial. But in this case, there's really a shared goal toward helping people. And then social service organizations are also invited into the room, and the people are essentially diverted to social services to provide that support. So that was kind of a model that was going on when I started Empower in 2013. Interestingly, and I got a lot of, so people would be diverted into social service organizations who then sent patients to me. And these could be people who are undocumented. It could be people who were citizens. More likely in the diversion courts were likely to be citizens, because if they were undocumented, they went toward the federal courts. But that said, in 2019, things seemed to change a lot, and this was pre-COVID. And I'm still starting to have initial discussions with law enforcement about it. But I do think, in a good way, there's increasing recognition that even though the diversion courts were a good thing, and we're trying to do a good thing, arrest and prosecution is traumatizing in and of itself. And we're doing the wrong thing by handling this problem solely through law enforcement. The question isn't so much, should these people be arrested or not? It's, what should we be doing for them in the first place? We should be preventing the traumas that lead to the vulnerability. We should be giving everybody the opportunity to have a productive and comfortable life so that they're not desperate to stay alive and engage in survival sex. And then when people are in commercial sex and may not want to be, give them an out and an opportunity to get out. And none of that requires being arrested. So I think increasingly law enforcement in New York City is recognizing that the arrest alone is traumatizing, even if you don't ultimately imprison the individual. And it's just adding to the layers of trauma that they've had. So I'm glad to see that. But then one challenge that arises there, and I'm definitely in favor, but one challenge that arises is our mechanism for getting support to people was through the diversion courts. And, you know, just relying on healthcare is not a solution, because as I said, half of the trafficked people don't have contact with healthcare at all. And those who do are often in a bad situation. So how are we going to reach them? And I don't think we've answered that question yet. The American system, all of our system is founded on criminal justice. And all of the institutions that we fund in this country and overfund have to do with criminal justice. The police having tanks and bulletproof vests and gassing their own people. And yet in hospitals, we can't even pay for cancer care for patients. So we overfund criminal justice and law enforcement, and then we underfund the rest of the things. And so I'm glad to see us moving away from using the criminal justice system in this way, but it has to come with an increase in support for the social support network that would help people in trafficking and in other desperate situations.
Mm-hmm. Mm-hmm. Thank you for sharing that. Thank you for sharing that. I'd like to raise the question again about victims versus survivors. Are there opportunities for survivors to prosper? I particularly was impressed when I was on the American Hospital Association program, where they actually had a survivor who was in nursing school and pursuing a different type of life. Can either of you speak to survivors and what possible opportunities we have in place for them to survive, to really survive and to thrive? Don't all speak at once.
Well, I'll start off speaking about my experience with my own child. And so we were fortunate and not the typical situation when it comes to human trafficking that I, number one, was employed. I had health insurance. I could choose a counselor, and I was a nurse, and I had to take care of my own child at home. And never did I once think while I was in nursing school that I would be using that skill set at home so deeply. instead of on the surface, hey, how are you doing? But I also came from New York in the middle of the night and guarded my house, stayed up all night to go to court the next day. And so when you talk about survivors, you got to go back to ACEs, which we didn't get to speak about, which are adverse childhood experiences. And that the more adverse situations one has against them, the more likelihood you're closer to a death. And so the stress and everything can give you negative outcomes. And so surviving is basically a term that's different for every individual. It depends on so many different factors. And how do you get a person who may feel so bad about themselves, blaming themselves, to turn around and feel good about themselves and love themselves and apply the word survival to themselves, so it's not just the act that I'm still living today. It's, do I feel full of life today, or do I feel like I'm dying every day? And so, yes, there's a lot of hope, but people need support. And I'll stop there.
Very good. Thank you. Thank you. Anyone else wish to address survivors and what supports are in place to help them to not just to survive, but to thrive now?
Yeah, so I look at it in a holistic view, much like Ingrid. I know Dr. Veronica talked about it, but for me, it is providing holistic, comprehensive services, a little bit of everything, from having social support programs to having education provided, to having empowerment, counseling, letting that person be in control to what they want and how they want to live their lives, right? Like human trafficking is power and control, giving that person back control, empowering them, especially if they have been disempowered, oppressed, and marginalized and abused for so long, letting that person take the lead and continuing to foster that trust. There's such a magic that can happen in fostering a trust between one person. For example, in the therapeutic realm, fostering a trust with a therapist can lead to trusting yourself and applying that medicine, that process, that healing back into you, right? I always say when we heal ourselves, we heal others. So it's really empowering the individual to take ownership of their life and also meeting them where they're at, right? So again, going back to what Dr. Veronica was saying, it's really, really important to build these trusts and to work with them little by little and to let them be the lead, right? So it's really important to look at, what does this person want? How can I support them? And how can I be on the passenger side whenever they want me to?
Excellent. Ingrid, if I may go back to you just one more time before I ask every panelist to just give me a 1-minute summary. But Ms. Ingrid, would you do this? We're talking about survivors. Could you tell us who your daughter is today?
Surely. In 2005, she was a 13-year-old teenager who was an honor roll student at the top of her game. And people assume that they're like just runaways with bad grades and no education. Today, my daughter is a college graduate, and she is the mother of my 8-year-old granddaughter. She's gainfully employed and really doing something she loved, which is working with other children in our school system and being there for children with special needs.
Very good. Thank you. I thought it was important that we share that.
Thank you.
So we share that success. Okay, 1 minute, going around the square. Any last thoughts before we ask Ingrid to talk about advocacy? Anything else that you might wish to add? Bernard, Dariella, Veronica, any last thoughts, please?
I just think that there ought to be, I'm an educator, and so my last thoughts are that there needs to be a lot more education. What we're doing tonight is very good, by the way, if I can pat ourselves on the back in terms of education of nurses, but there should also be education of lawyers, education of law enforcement, and education of doctors, all on this problem, because there are more people trafficked today in around the world in both other thing I wanted to say, we also have overlooked that we talked a lot about sex trafficking, that labor trafficking actually involves more people than sex trafficking. And it often doesn't end up in the emergency room or in a hospital or doctor setting. Nail salons, restaurants, hair braiding operations. There's all these places where people are being put under forced labor conditions. Okay. So that should not be overlooked in terms of this problem. And it should be like in high school curriculums. That's what I would think. And other places like that where people can be aware of it.
Education.
So it doesn't hide in plain sight.
Right. Like education is essential. Education is very important.
Right.
Dariella, anyone last words, please?
Yeah, I think that my last words to you all is really to never underestimate the importance of authentic human relationship. I have worked with I've worked in special victims units, I have worked in schools and foster setting, and one of my biggest takeaways was one day at 2 a.m. getting a call, having to go and help a survivor, a 14-year-old who was running away from the foster care system. And she said, "I like you because you're real." And that stuck with me because we were in the hospital and people were talking to her. And of course, someone was looking at her in the eye, and there was just so much going on because it's 2 a.m. And I sat on the floor with her and she told me her story. And there was such a authentic compassion and just nurturing to her. And she just wanted to be heard. And it was just such a powerful moment for me and for her. And for the community as well, because I've always shared that story, and I always share that sometimes you just have to sit on the floor with a survivor, with a person, and just hear their story.
Right. And we didn't use it a lot, but you used it just now, compassion. Compassion, for sure. Dr. Veronica, any last one word for us, please?
Well, obviously I can talk all day about it, so I won't, but I will say this to the audience. If anyone's interested, there's a lot of great questions in the chat as well. If anyone's interested in hearing more about my work, and we also do a lot of advocacy, I'll put my lab website and my Empower Center website in the chat box so that you can follow up. In the lab, we have a newsletter that's monthly. It's short and sweet, and it tells you the different advocacy work that we're doing, the talks that I'm giving, any publications or presentations that come out of our research, so you can keep up with the research that we have, and even any presentations that we've done. If we have videos, they're on our website, so you're welcome to review those. And then we have Instagram, Twitter, and Facebook. Well, our Facebook was hacked recently, but our Instagram is really great. And we do a lot of awareness raising through that. And so by following us there, you can learn more about this and other forms of sexual and gender-based violence.
Okay, thank you so much. And thank you for placing that information in the chat. Ingrid, we would like for you to have our parting words over the next 3 minutes. And if you would address advocacy and how nurses can advocate for better care for human trafficking victims, please.
Okay, so thank you for that. And this has been outstanding to be with all of you tonight. And hopefully my summation will include your thoughts as well. And so I like to start with encouraging folks to bring hope to the hopeless, to be the voice for the voiceless. And don't just try to reinvent the wheel. Collaboration is key. And bring your leaders to the table and work on them no matter how long it takes. And so those things are highly important. There are a lot of resources that are available. I really suggest that you look each one of us up as speakers. We have a lot to offer collectively. I will just name a few things to bring forth. Not being selfish, but really good stuff is the organization that I am a board member for and on the co-chair for the healthcare committee. SaferNewJersey.org is for the New Jersey Coalition Against Human Trafficking. We don't just speak about things that are just pertinent to New Jersey. So I think you can learn something from that site. There's also the National Human Trafficking Hotline, and you can go to their website, which is humantraffickinghotline.org. They have a phone number, 888-373-7888, or you can text Be Free to get lots of information and even to help other people. And so also you should encourage your leaders wherever your involvement is, locally, nationally, within your organizations, that they should be encouraged to do something to stand up in this fight against human trafficking. You can go to the American Hospital Association's website, also their website for Hospitals Against Violence, and find tons of information that is across this nation. And also Heal Trafficking at their website, healtrafficking, all one word.org. And so this has been very powerful tonight. And I think that hopefully we've done justice to touch base on some key aspects of human trafficking and help you better understand what it is. And for most importantly, that tonight it shouldn't stop here, that you have space in the fight against human trafficking. And we need you desperately. We need your ideas. We need your energy. And so that we can help survivors become thrivers.
Wow, thank you, Ingrid.
Thank you very much.
Yeah.
And I thank the entire panel.
Yeah.
This has been so very informative and rewarding. And I hope that we can address any outstanding questions. We'll turn it over to you now, Renee.
Of course. Thank you so much. So yeah, we have a couple questions in the chat. So the first one is, nail salons are reported to be places where people are trafficked in plain sight. What does one do here? Are there resilience factors? Are there signs that a victim can become a survivor? So this is open to all the panelists. So I don't know if anyone wants to take the lead on that question. It's kind of a two-parter.
Well, I have, it's actually happened to me when I've gone into to get a pedicure. I've wondered about it myself. And I think you have to be very careful in those circumstances to not accuse before you're on solid ground. So usually with the help of law enforcement. So an inquiry, you could inquire of the worker, but if you can't be assured that the worker will not be retaliated against, it's best not to do that. The local police department is probably the place to go if you have some suspicion. It's easy to have suspicion in these circumstances that turns out to be groundless. So you have to proceed carefully, and I would not recommend that someone be their own detective or, one man sort of anti-human trafficking, unit, but to talk to the local law enforcement people if you have grounds to believe. There was a hair braiding salon in East Orange, New Jersey some years ago, where the woman was bringing in African immigrants from a large family group. And I think the country was Togo or perhaps Ghana, I don't remember now. And it turned out that there were all these young girls that were doing hair braiding and were not really having any, couldn't see the light of day and were being abused. So the presence of children in work is one red flag. If there are children and other young people in those circumstances, that's a red flag. And then other people avoiding talking about things, it's hard to really say. You have to be very careful about how you investigate something like that. Better to have law enforcement at your side rather than doing it yourself. That's what I would say in answer to that question.
Okay.
Does anyone else want to comment from the panel?
I think that nail salons are a known site of labor trafficking. I think especially within the Asian community, one of the things that we see that happens, so there's certain flows of how people enter trafficking. I talked about the Latino community and I talked about the foster to trafficking pipeline, but there is also an increasing amount of trafficking, or there was, coming from mostly China, but a little bit from Korea, where they're brought expecting a labor trafficking job. So essentially the person signs up to know that this is going to be somewhat exploitative, but they might get opportunity later. But then they get here and then it turns into a sex trafficking job, which is kind of an interesting dynamic. The labor trafficking in and of itself is abusive, but in some ways is what they envisioned, still not good. I agree with Bernard that I don't think on the individual level that it's very safe to do anything. You could be endangering yourself the victim and really everybody there. But I also think that anybody who does have a strong suspicion of trafficking has a couple of ways to go. They could call their local law enforcement. And there's also the Polaris Project has a national hotline where you can call in for more information about, I thought maybe this was a trafficking situation. I need more information. And they actually track the cases and they can connect you to local services.
Yeah. There's another place where people are trafficked from a lot from Asia is Fujian, this area of China, going toward, it's sort of between Hong Kong and Shanghai. You find a lot of people coming from there. I don't know why, but people, it's like slavery. It's the same as slavery. They develop these networks, transportation networks, and then people who are actually looking for a better life on the Chinese end, oftentimes they take advantage of it, like smuggled people everywhere. But then when they get smuggled in, suddenly everything flips and they're enslaved after they get here, oftentimes without much choice.
Wow. We do have another question. Someone said, thank you for this amazing and informative program. My question is around research and studies to examine how to identify and support human trafficking victims. Are the panelists aware of any cross-sectional studies going on, for example, between medical personnel, law enforcement, or doctors and nurses, etc., that may help to inform the medical and law enforcement community?
I think, go ahead, doctor, go ahead.
Yeah, that's a lot of the work that I'm doing right now. And as I said, we actually have a publication submitted looking at screening tools and their validation, for example. And then there has been a lot of good work done by other people. A lot of them are in the HEAL trafficking network that Ingrid mentioned. That's a really helpful network because it compiles a lot of the research being done and it has a whole research arm. So I do think that there's research being done. Certainly not enough. It's a very small community doing research on the subject. And it's also very difficult to do research on because it is such a clandestine phenomenon. And I would say that the research being done on the law end is very siloed and separated from the research being done on the medical end. And so we've done a little bit of work within my lab trying to unify those two. I will say that the two disciplines do research in very different ways. So it's really hard to align them, but it is important. And so again, if you're interested in the work we're doing, please do sign up for our lab newsletter and check out HEAL Trafficking because they're also a great organization.
I would also recommend you check with the UN Office of Drugs and Crime. They oftentimes sponsor research or are interested in sponsoring research. It's more international than domestic, but the UNDOC, I think it's called, oftentimes, UN generally may have funds. And I don't know what the Department of Justice is doing right now. During the time of George W. Bush and into the time of Barack Obama, less so with Barack Obama, there was quite a bit of funding for research coming out of DOJ, but I think that dried up. But it might be worth it to inquire now what the DOJ is interested, that they have a department that funds research like that, like the questioner asked about, pilot studies and things like that. And it might be a good place if the person's looking for a funding source.
Okay, thank you. Actually, another question just came up, which is something I wanted to ask, was how has the pandemic, like how has COVID-19 affected survivors and victims of human trafficking? Has anyone seen any kind of like situation that has occurred or barriers around the pandemic in regards to like survivorship or even just seeking help?
Yes, I was a part of a panel discussion recently about this topic. And we discussed how with the mask wearing, people are fearful that their perpetrator is hiding behind a mask in their community. There are Wi-Fi issues now that you need to have some sort of connectivity and technology to help communicate and get appointments and what have you. And so transportation issues, obtaining documentations, much needed documents needed for court and etc. and just to get on with your life and get on the path of really surviving and thriving. And so those are some of the key issues that were around services in the community that were making it quite difficult for survivors.
Yeah, I bet. Wow.
I think to add to that is that a lot of trafficking way pre-COVID, but moved from being street prostitution to online. So most of the solicitation is online. And so what's interesting about that is that the pandemic didn't really affect that. That most trafficking victims don't have a lot of choice and don't have a lot of ability to protect themselves. So they're still being exposed to COVID and to Johns without a lot of decision-making power around that, unlike other industries. But at the same time, it has really decimated a lot of the efforts that exist in order to provide protections and identify. So one example is the Family Justice Center is a really wonderful, it's not an organization, but a department that works within New York City, has a branch in every borough and connects intimate partner violence survivors to social services. And that's actually where a lot of trafficking survivors can be identified because of the overlap. But since the start of the pandemic, the Family Justice Centers have not been taking walk-ins, which is really difficult. So you have to call, make an appointment. It's very hard to get a call back. So while people being trafficked are still being trafficked, the ways, the routes, the organizations to identify them are inhibited. For us at Empower, we launched our comprehensive center in January 2020. So by March 2020, we had to stop being in person, and it was really supposed to be a walk-in center. So from our perspective, it changed everything about how we administer services and what we do. In some ways good, because we found that a lot of survivors are much more comfortable with technology. And in some ways it's more approachable to reach out by text message. And so many of them first text with our peer care navigator before they get engaged in services. But on the other hand, has reduced our ability to meet people in person. And that in-person connection is really important for trust building. Yeah. So we've tried to replicate a lot of things by using technology, but it's not perfect. And then I think the other thing too, is that with these changes in the diversion courts and the changes in prosecution and arrest patterns that were happening before COVID, what the pandemic added to that was that these people are probably still out there, and we just don't know, is there actually a reduction? I do think there's a reduction in identification of trafficking, but I don't think that necessarily corresponds to a reduction in actual trafficking, which means that there's more people going unidentified.
Wow. Wow. Thank you so much. This has just been a great discussion this evening. I just want to say a huge thank you to all our panelists and sharing your experiences and your expertise with our nursing community. We appreciate all you're doing to support the victims and survivors of human trafficking and providing such great insight to us as we take it to our practice. I also want to personally thank Dr. Hallie Boyce for facilitating tonight's discussion. She did such a great job. Again, we'll be sending you a follow-up email later after this event. We encourage you to share your feedback about the program. And we thank you so much again. Everyone stay healthy and safe. And, a special thank you to Ingrid. You're so strong. I just want to personally tell you, thank you so much for sharing your story. It's just incredible. I can't even imagine what you went through. And it just, from a nurse to another nurse, I am so impressed by you and your strength. So, but yes, thank you to all the panelists. And this was a great program, and we're just going to end now. So have a great night, everyone. Thank you.
Thank you so much
for coming. Yes. Be well.